All right. Hello, everybody, and welcome to BariAftercare, the podcast. And we have a very interesting topic tonight and some amazing professionals joining us. One you probably know, and one probably you don't, but you are going to know her and love her at the end of this episode. So, we're going to be talking about the disease of obesity and fertility and infertility and how that all intersects. So, with me tonight, I have a physician that I have known, oh my gosh, for 20 years, which blows us both away, Dr. Carter Owen. And she is an infertility specialist. I'll let her introduce herself in just a minute. And you probably all know Kate Fuse, who works at Beltline Bariatrics, physician assistant in Atlanta. And so, welcome to both of you. But let you introduce yourselves just a little bit more. Can I call you Carter instead of Dr. Owen?
Sure.
Okay, but nobody else gets to. Because I knew you when you were Carter before I knew you were.
That's right. Before I
Before you were
graduated, I got
Dr.
that
Owen.
MD. That's right.
That's right. Okay, now you're MD extraordinaire. So, just kind of tell everybody about your journey to where you're at.
Sure. So my name is Carter Owen. I'm originally from Augusta, Georgia. I met Connie when I was a student at the Medical College of Georgia. And I did OBGYN residency at University of Pennsylvania after I'd done research at the National Institutes of Health. I did most of my research on uterine fibroids and genetics. And when I finished my OBGYN residency at University of Pennsylvania, my mentor said, you got to go, come back to me. So I went back to NIH. And then he said, you got to do this other fellowship. So then I did REI, Reproductive, Endocrinology, Infertility with genetics. So instead of doing 3 years of fellowship, I did 4 years of fellowship because I'm a glutton for punishment, and Connie knows I'm a giant dork. So, I ended up doing a combined fellowship in both specialties, and learned a lot about PCOS. And in practice, I'm at CCRM Northern Virginia. I've hit the jackpot on jobs. We are known for our science, and I get to have awesome outcomes with my patients and get to hand off, eggs and sperm to this awesome lab, and then I get to take care of my patients. But I do
Meaning
talk.
you help people get babies. You help people make babies.
I do help. I do help patients make babies. That is my job for a living, and it is the coolest job in the world. Uh, but yeah, I live in the Washington D.C. area. That's where our clinic is. So I've moved away from Georgia, and yeah, that's my story.
And have babies of your own.
Yes.
So I take it back. All that's cool. I'm calling you Dr. Owen. All right, Kate. So for those of the listeners who don't know you, which can't be many, just tell us about yourself a little bit.
Well, I'm Kate Foose. I am a physician assistant. So I did my training to be a PA in North Carolina and love surgery. So I did a postgraduate surgical residency program up in Connecticut at Norwalk Yale. And then met my husband, bounced around the country a bit and stayed in surgery. Always took care of bariatric patients. They were my favorites. I loved seeing the bariatric patients in the hospital. So I always had hospital and OR jobs. And then we moved to Atlanta. We lived in Fargo, North Dakota. So I hit my limit on Midwestern weather. I grew up in New England, so I was ready for some heat and settled at an amazing job in Atlanta where I just work in the clinic setting, taking care of bariatric patients post-operatively, which has been equally fulfilling because surgery is a tool and our surgeons are incredible and give our patients that tool. But from a patient standpoint, the hardest part is the long-term support and care that comes with living a life with having had bariatric surgery. So this topic is super relevant to my own interests and also helping patients because a lot of bariatric patients are female. And it's been really cool to see women's dreams of becoming mothers and having fertility restored in their life back. And so that's been really awesome to help them navigate that as part of their life after surgery. So excited for this and really honored to be here with these two prestigious women and all of their experience. So I'm eager to learn from everybody too, and will likely have my own questions, which I should probably just get my notebook out anyway, so I can keep track of my little questions that I have for later. But yeah, that is me.
And Kate also has a toddler and a baby coming.
I do. And as I'm doing this recording, I'm like, I should have tidied up my toddler messed up hair here who was playing with me before this recording. But yes,
Oh,
I
my
am a
goodness.
mom. So it's relevant for all of us mothers here on this call.
Yes. And I want to say that this podcast idea was Kate's. And we were just talking. I don't even remember how the topic came up, but, because there are a lot of fertility struggles with bariatric patients, people who suffer from the disease of obesity. And we thought this would be a really wonderful thing to get into. And because I've known Carter for so long and know that she is so good at what she does, Kate and I thought, let's put our heads together. And Kate, too, has much more of a medical background than I do, although I think she's part psychologist because she gets the whole picture. We thought, let's get some information. So we're going to go ahead and start. We'd love your feedback because if there's more information you have than what we share on this particular episode, hey, we'll do another one, just like we did with the gut biome stuff. That thing just keeps growing and growing. And I don't mean the gut biome. I mean questions I keep
Probably
getting
that
for
too.
more information. Absolutely. All right. So we chose this topic because so many people, so many women who do struggle with the disease of obesity have a lot of comorbid medical issues that can affect fertility. And I don't have any medical background, so I needed the expertise of these two ladies. And I do know that some of the issues involved with the disease of obesity and fertility involve PCOS and insulin resistance. And I don't really know the connection between those two things, and probably things I'm not at all familiar with. So let's go ahead and start there. So, Dr. Owen, and Kate, let's just start by talking about how does having the disease of obesity interfere with fertility, and what are the risks associated with having a high BMI and pregnancy? So those are really kind of two questions, but wherever you want to take that, Carter.
All right. Well, let's start with PCOS because I think that one is probably easier. That's the softball. Let's start with softball.
Okay.
So, so PCOS is the most common endocrinologic disorder in women. It affects like 20% of women is what's estimated.
That's a lot.
Yeah, it's like 5 to 20%. So there's a very wide range, and there's a wide range because the literature hasn't always agreed how you define it.
So is that 20% across regardless of weight?
Yes, there's lean PCOS and there's patients who have higher BMI. Yes.
Okay. So is there, see, questions, here I go, segueing. Is there a higher percentage either way, or is it just kind of spread across equally, the lean and the not so much?
Most have obesity as part of their disease.
Okay.
And most
Thank
have obesity as part of their disease because most have insulin resistance. And they have insulin resistance because whatever is going on with their programming, and we don't exactly know why they get it. There does seem to be some sort of genetic predisposition, but it hasn't been determined to be a single gene disorder or something like that. Like you can't just, fix it if you fixed one gene. It seems to be multifactorial is the way we describe that in genetics. But it does seem to run in families. So if you get the history that someone's sister or mother had PCOS, they'd be more likely to have it too. But
So go ahead.
so what happens is the ovary makes extra androgens, male hormone. And when the ovary makes extra male hormone, and we're talking about like testosterone, they then will start to get like a whole plethora of problems. PCOS cannot be cured. We manage it. And depending on what stage of life you're in, that's how we determine what we're going to do about it. So I'll get to that in 1 second. Let's go back to the physiology. So if the androgens go high, that's what makes the insulin go high. And when the insulin goes high, you get the obesity because your body gets into a mode where it says, I'm going to store fat, and you get the central adiposity. So this the central deposition of fat, that
Meaning you get a bigger belly.
apple shape, yep.
Okay.
Which we associate with metabolic syndrome and elevated cholesterol, increased risk of diabetes. And the issue is that when the insulin goes high, it actually decreases your sex hormone binding globulin. So sex hormone binding globulin is actually this thing in your bloodstream that goes and grabs testosterone, takes it out of the bloodstream, and that would help fix the problem. But because you're actually decreasing it, it actually feeds forward and makes you have more testosterone, more insulin, more testosterone, more insulin, more testosterone. So it's like this horrible vicious cycle that you have to break. And that's where what you guys do comes in, because one of the ways to break the cycle is weight loss.
Okay. So I'm just going to make sure I understood what you said.
Sure.
Okay. So PCOS, we don't know exactly what causes it,
Right.
but we know it's not a single gene.
That's right. Multifactorial.
So, but it does seem to run in families.
Yep.
So PCOS is not caused by the disease of obesity.
No.
But if you have PCOS, it's more likely that you will develop belly fat.
Correct.
Okay. So
Because
I'm tracking.
insulin's high.
Okay. So now we have the PCOS. Is the insulin resistance, which we'll talk about more, a byproduct of that or its own thing? And they just happen to coexist, or it can be both.
The core issue, and let's define PCOS. We didn't say what it means. Polycystic ovarian syndrome. And it was named that by some old dude who was looking inside someone's belly with a laparoscope back in the day when they put the thing up like this.
Well, how rude.
And he's long time ago. And no video. And so he's looking in this woman's belly and he goes, oh, look, that ovary looks like it's covered in cysts. And so we called it polycystic ovarian syndrome. And it could be called polyfollicular syndrome. What's a follicle? A follicle has an egg. It is my favorite diagnosis as an REI because it means you're chock full of eggs. It is a much harder problem if you don't have eggs. It is a much easier problem if you are in excess of eggs. So their buckets are overflowing with eggs. But again, the core issue is that they have too much testosterone being produced by the ovary. Normally, it should be proestrogen and less like testosterone, and it's reversed in this state. So you have too much testosterone, not enough estrogen, and the excess testosterone is what's causing the high insulin, and the high insulin is what's causing your body to go into that metabolic state where it's like, I can't burn fat, I must store it. And that's why you hear patients with PCOS say, I'm doing all the right things. I've got the diet down. I've got the exercise down. I'm doing everything you tell me to do, doctor. And I'm saying, hey, if you just lose weight, your PCOS will get better. And they're like, F you, I'm doing everything right and it's not working.
Yes.
And you need help. So you need, the doctor, a Kate and a Connie, to come talk to you and counsel you about what are the other ways that we can break the cycle, because you doing all the right stuff usually isn't enough.
Absolutely. And what I have learned in the 20 years I've worked in this field is that PCOS, I boil it down to, makes it darn near impossible for you to lose weight without some kind of intervention.
That's exactly right. Because it's a vicious cycle. It's a vicious cycle. You have to break the cycle.
Okay. So that, I hope, for anybody listening who has struggled with this, A, may help you understand it better, and B, can help you have a little compassion for yourself.
100%.
Because when you're struggling with the disease of obesity, it's beat myself up game like none other. So, Kate, in your experience with the patients that you and I work with, whether or not they're struggling with fertility issues or not, what do you want to add to that?
Well, this is the exact runway that we see leading up to bariatric surgery. We have patients who have tried everything, and we have to explain that the disease of obesity is a chronic, recurring, relapsing disease state, and it's a process. So, patients will have tried every diet fad. Maybe they've tried a lot of the weight loss medications as well, and their bodies just rebound back to the weight. They'll lose weight. It's the yo yo, it brings them back to a set point. Bariatric surgery is also a metabolic surgery from that standpoint of it will help reset and change a patient's metabolic set point to help them lose weight and keep it off alongside the behavioral lifestyle dietary requirements that come with the anatomic changes you're making with the surgery itself. But it is a bariatric and metabolic process that happens. So hormones are affected and hormones are changing. And this is exactly what we see. So we see a lot of our patients with obesity, which is usually, a byproduct of other medical comorbidities, high blood pressure, as we were mentioning, high blood pressure, type 2 diabetes, high cholesterol, sleep apnea. I mean, there's a whole laundry list of things. Insulin resistance, which typically also comes with the type 2 diabetes, PCOS that we see in a lot of our patients as well. And also women as they enter menopause. So there's the hormonal component that factors into it as well. So then you have these patients, and now bariatric surgery is one of the only things that can put a lot of these conditions into remission long term. So when we're talking about type 2 diabetes, we're talking about insulin resistance. We have objective data when we collect these patients' labs after subsequent weight loss to show that these hormones are changing and the quality of their health is improving, especially from a diagnostic standpoint. So their high cholesterol, lipids, triglycerides, blood pressure drops. A lot of these patients, even within a month after surgery, are either cutting their blood pressure meds in half or they're coming off their blood pressure meds altogether. We do track their fasting glucose and their fasting insulin levels, and we can put it into an equation to calculate if they have insulin resistance. And typically we'll see, it's a little bit of a slower progression, but we'll see insulin resistance transition to pre-insulin resistance, which is kind of like the precursor, until they're sugar control, their glycemia has normalized. And that parallels with their A1C. So their A1C comes down into, if it was a diabetic range, a pre-diabetic range, and then a normal range. So we also see from a fertility standpoint, and we tell our women this, especially childbearing age, make sure you have pregnancy contraception on board. Try not to get pregnant within the first year after surgery because fertility spikes after bariatric surgery. A lot of these patients can lose dramatic weight loss the first 6 months after surgery. And, and their hormones, right? They're shedding fat, estrogen released from fat cells, that's changing their periods and their cycles. And we see that's a whole other conversation, the GYN component of that as well. But fertility, so making sure they have pregnancy contraception on board because they will, we want them focused on their weight loss the first year. But there's still high risk for, getting pregnant during that time. We can talk more about pregnancy and gestational risk with that. So there's a lot of things that we see that piggybacks off what Dr. Owen was saying. But yeah, it's common. And when a patient has insulin resistance, listen, you're right. They've tried everything, even after bariatric surgery. They're compliant with the guidelines. High protein, low carb, they're exercising, they're doing all the things. And sometimes it's slower weight loss because there is a hormonal component to this that can really stall their progress. So
I want to come back to a lot of the things you just said there, Kate, and clarify one thing. It's not the surgery that improves the comorbidities, it's the weight loss that improves the comorbidities. Correct?
that is a big teaching point. Surgery is a tool. It is
Right.
how you use the tool
Yeah. So
consistently.
surgery doesn't fix any of that. The weight loss fixes that. So I was chuckling when you said we're telling people, be careful, you might get pregnant. And so from Dr. Owen's perspective, it's like, are you kidding me? You're going to tell somebody who's been trying to get pregnant for 3 years to hold off?
Well,
And that's exactly why they want to have the surgery, to have the baby.
well, it is challenging from my perspective, because if I have a patient who's older, because of the year that they need to wait, and the reason Kate and her team is counseling this way is because of the nutritional component,
Right.
because of the rapid weight loss, and because you are inviting a happy parasite into your body that needs the nutrition, right, that you're going to
calling
provide.
a fetus a happy
I
parasite?
am.
Okay,
I'm
just
calling
checking.
it a
I'm like,
parasite.
wait a minute. What? Is
Yes,
this
you
what
are.
we're talking about? Okay. All right, go ahead.
Yes. So you're going to invite a happy parasite into your body. You have to be able to, take care of yourself as well. And in that first year after that weight loss surgery, you are shedding, a lot of weight very fast, and your ability to absorb the nutrients has been compromised. And you do take the bariatric vitamins and all the stuff that Kate's team will advise you to do to make sure that you're staying well. But it's a very big tax on the body to invite a happy parasite in during that time. So that's why it can be problematic for me, because age is the most important factor when it comes to fertility, no matter who I'm seeing, because that's egg quality. There is no test for quality. It's what is your date of birth. So if I see a patient who's like 40 and has a high BMI, weight loss surgery is a tricky thing to advise, because it's going to take a long time for her to come back to me to be able to be pregnant.
So this has nothing specifically to do with this conversation, but I do need to ask this question to you, Carter.
Yes.
Do you recommend that young women, the healthier age range for eggs, healthy eggs, do you encourage young women in this day and age to do egg retrieval and freeze those suckers just in case?
I see patients for egg freezing every day. I saw 2 of them today.
Do you think it's a good idea?
It is totally dependent on their life circumstances. And up around where I am, there's all these big companies that are encouraging their employees to focus on career and put family building
Oh,
on the back burner.
wow.
So it's covered. And they're like, I don't have my partner yet, focused on my career. They're going to pay for it. It's free. Why not?
Yeah.
So, and it's not a bad idea. And I always tell them, this is not plan A, it's plan B. You're putting an insurance policy in place.
Mm-hmm.
And for the patients who are bariatric patients, we need a BMI less than 40 for anesthesia.
Oh.
And that's almost every fertility practice, because we almost all have outpatient surgery centers. And we almost all have outpatient surgery centers for the experience that Kate's probably remembering from her time in the surgical OR, where if it's not your room and you don't have complete control over the OR schedule, you're going to get bumped. You're going to, someone's going to have an emergency who's going to come take your room or something. You got to have control over your OR schedule, because we precisely time the trigger to release the eggs with the time we do the surgery to extract them.
Wow.
And if that were to get all screwed up, you're not going to get the right maturity of the eggs, or the patient might ovulate and then you don't get any eggs at all. So it's very precisely timed. 35 hours for us at CCRM between trigger and retrieval. So
Wow.
pretty much all of us have an outpatient surgery center. There are a few exceptions of programs, usually academic, that are still operating in a hospital setting. And so they will usually accept a higher BMI. But otherwise, there's lots of papers out there about, are we being discriminatory, saying that they need to have this lower BMI, but it's almost always for anesthesia risk.
Okay. So that sounds like a wise thing to do.
Yeah. So we use cRNAs for our anesthesia, almost all of us in these outpatient surgery centers. And they are awesome. They are very skilled. And most of them also work in the main OR, like we're their part-time job. Okay. So they're doing very complicated cases. Otherwise, they know how to intubate patients. But if you had to emergently intubate a patient with a higher BMI, issues can come up. and we are 8 minutes from backup
Okay.
and from, like extra help. 8 minutes of not having enough oxygen, that's very serious. So we have to be careful and set guidelines about what we can do safely in our surgery center.
So if you're a listener, or if you're a listener who knows somebody who is frustrated because they've gone to a fertility specialist who says your BMI is too high, it's too much of a risk, this is the reason why. And even though it's got to be terribly frustrating to the person trying to get pregnant, it's for very, very good reasons. So, Carter,
Mm-hmm.
what is the biological reason that as a person loses weight, they are more likely to get pregnant? And how does that affect the PCOS thing?
With the PCOS part of it, it makes perfect sense because you've broken that cycle. You're going to get them ovulating again. So we didn't get to the part where I said it's a condition that cannot be cured. It is managed. So when they're a young girl, they're having irregular cycles. Everyone says, here's a birth control pill to regulate your cycles. Later on, they want to build their family. They come see a doctor like me because they're not ovulating. When they're having those irregular cycles, they're not ovulating. And the way you can think about this, I said it's a disease of excess eggs, right? Again, my favorite diagnosis. So it's like the brain is the teacher, and you have a classroom full of students, the eggs. And the brain asks the classroom full of students, so and so, stand up. The brain is trying to ask someone to be the dominant follicle to ovulate. There is so much chatter in the classroom, no one will stand up. So they go long periods of time in that follicular phase before they will reach their ovulation. It is not until you have ovulation that you will get a corpus luteum, the cyst that can support pregnancy, that has a clock on it, 2 weeks. And then if you're not pregnant, you bleed. That's how you get to a period. So that's why the irregular cycles happen, because they're not ovulating. And once you break the cycle and you get the hormones from the brain talking correctly, you get the teacher talking to the classroom correctly, then you will get your ovulation and your period. And with no egg dropping, you cannot get pregnant.
Okay, so let me just make sure I have this clear, and then Kate, you can jump in. So the weight loss breaks the cycle of too much testosterone.
Right?
And so the woman's body starts behaving like biologically it's intended to for all of us, theoretically, right?
Mm-hmm.
And so it makes it much more likely that you will ovulate, and that gives you an opportunity to get pregnant.
Correct. That's it. They're just
Oh,
ovulating.
dang, I tell you what, medical school minus 101.
Medical College of Georgia,
Here's
baby.
medical school right
Okay,
here. There you go.
so my
Condensed in
question
5 minutes.
here, my question here is, because PCOS is not curable, we manage it. Does that mean when your weight regulates, if you maintain a healthy weight, can that cycle stay broken and you can continue to
Correct.
ovulate? If you regain weight, then does
It'll
that
be over.
interfere again? And so even with weight loss surgery, which is metabolic and changes things, resets, whatever, when your weight gets stable, right? Kate, does the PCOS interfere again if there's no regain, or does that? But
With fertility.
yes. Well, no,
So,
with PCOS, yeah, and fertility.
so when I'll comment on just like the degree of weight loss and how it affects what I see in practice with patients' ability to get pregnant, and the return of their ovulatory cycles. I mean, we have women that within a month or two are regular. I mean, it's quick. Sometimes it's it's hard because they're used to having irregular periods, they're unfamiliar with what that looks like, and so they can prematurely get pregnant without planning to. And so that's the other problem we ran into. I've had patients who within like sometimes are 6 months out from surgery and they're pregnant, and it was like an uh-oh, I wasn't planning for this. I wasn't expecting things to happen so quickly. And we manage it, and they've had healthy pregnancies. But from a pregnancy standpoint, let's say they do get pregnant. I can comment on what changes we make after surgery briefly while this is top of mind is we immediately change the kind of vitamins that they're taking. So the bariatric multivitamins that we have, and also the concentration of vitamins and minerals inside of these vitamins varies based on the kind of procedure that they've had, low, high amounts of vitamins. Vitamin A, so very specifically, but there's a specific kind of vitamin A that are in these vitamins that can be harmful to a developing fetus. And so immediately we want them switched over to a prenatal bariatric version of these vitamins for the safety of their pregnancy. And then some other traditional prenatal supplements that we also recommend: choline, DHA, EPA. Um, Aside from that, most patients, if it's early on, they're still in the high BMI range. So the what is it, ACOG, the American College of Obesity and Gynecologic, their organization. So they have BMI cutoffs for weight loss, or excuse me, not weight loss, for weight
Weight
gain,
gain.
how much you can gain during pregnancy. And so often for our patients, I'm taking inventory of where they are at a weight standpoint at the start of their pregnancy. And a lot of patients, if they start high because they still haven't entered below a certain BMI into a healthy obesity category or overweight, they may not gain weight at all throughout their entire pregnancy. They may lose weight. They're losing fat. That's the predominant form of weight that they do lose after versus muscle mass. We still have the same guidelines, still having protein. Maybe we push their protein needs by 20 grams or so, eating a little bit less frequently throughout the day. The nutritional nuances are hard because now we're blending recovery from a bariatric surgery with first trimester pregnancy symptoms. You have patients that are high risk for vitamin deficiencies if they're nauseous and throwing up and they can't get through the first trimester blues, but then they can't take their vitamins and they have a severely malabsorptive procedure. Like, these are the dangers that coincide with having pregnancies during that first year of stability after surgery. They're higher risk for having larger size babies. So we also, which can complicate pregnancies, gestational diabetes risk goes up. So we always pair consultation with a perinatologist. So we always or a neonatologist, I should say. So they're under a higher level of care during their pregnancy. So just little nuances at that point in time for how to manage a pregnancy. And again, this is why we emphasize the contraception. Now, to Dr. Owen's point, it's hard because when a woman wants to get pregnant, there is a ticking time clock. Aren't we all aware of this as women? It's like,
Get out of
okay,
my way. Yeah.
yeah, a lot of women are working. And so we're not having pregnancies in our 20s. We're having them in our late 20s, early 30s, or later. And so it's like, when we're ready, we're ready. And then you've got a medical condition that feels like it's out of your control because despite the things you're trying to control to lose your weight aren't working. So what are your options? They come to us. We can do medical weight management, but some of these medications you cannot be on for 2 or 3 months preceding fertility because of the effects it could have on intrauterine growth restriction, and there's other complications. The other thing I should say, speaking of medications, is after bariatric surgery, the efficacy, especially of oral contraceptive pills, do affect how they work. Meaning, all patients that come in for bariatric surgery are going to have a smaller stomach. How small depends on what surgery. And they have some malabsorption depending on surgery. When you swallow a pill, pills don't get absorbed as well as they would if you had your original stomach. So while a birth control pill is 99%, I mean, don't quote me on that, but 99% effective, right? That's not going to be the statistic we're dealing with after surgery. So even though you might be on oral contraception, you're not fully protected. Okay, so we always recommend intrauterine devices. Now, the other options are worth talking to your GYN about because they need to be weight neutral options for our patients.
Yeah.
A lot of the Depo-Provera and a lot of some of these other implants can cause weight gain as a side effect. Oral contraceptive pills are no different. So we kind of balance a lot. All right. So yes, so you can do the quicker option with a lot of the injectable medications, right, that are on the market. There are some pills that you can also do to lose weight as well, and those can be effective if you don't have certain restrictions or contraindications for being on some of these medications, phentermine, topiramate, etc. Injectables have their own degree of limitations from affordability, insurance, access. So if you can get your hands on them, they're great. If you qualify for them medically, because some of these you need to be a certain BMI, you need to have certain comorbidities. Comorbidities are just health conditions related to the disease of obesity. The tirzepatide is a dual. We're getting into the medications, but
Yeah.
these are hormones again. So we're tackling this from a hormonal approach. And so some of these medications are pills, and then it's one hormone. Now it's two hormones. There's some in the pipeline that are three hormones. The degree of total weight loss that some of these medications are providing is comparable to the sleeve gastrectomy, which is what I would consider our most common bariatric procedure, where it's just your stomach. 75% of your stomach is removed. The outcomes now, you have to be on the highest dose of some of these medications and on it for a couple of years to really reach that level of weight loss as the surgery. But some of these other medications like tirzepatide, which is the dual, and the ones that have three in them coming down are superseding the sleeve. So the weight loss impact is significant. But again, you have to be on these medications. Like obesity is a chronic disease, so you can't stop these medications prematurely or the weight will come back. And now we're back into the same cycle that we've started talking about. So yes, you can do the surgery, but again, the timeline, to circle back to that.
Let me just interrupt here
Yeah.
quickly. And from Dr. Owen's perspective, I'm
Mhm.
guessing that the medications, the GLP-1s, and those are probably what you would choose over a surgery because of the timeline with the surgery. But the question I have is, as Kate just mentioned, you have to stay on these medications. So if you prescribe a weight loss medication, GLP-1 agonist type thing, to your patients, do you have them use that just until they reach the BMI threshold that's safe for getting them through the fertility process, or what's that with you guys?
It's a shared decision that we make, and it depends on age and goals and like what's going on with the couple in front of me. But a lot of times, uh, we'll be maybe planning IVF. So if we're planning IVF, we're trying to get to the BMI 40 so we can get those eggs out of them. The ticking time bomb is the eggs. The uterus is a hormonally responsive muscle. I can get someone pregnant up to the age of 53. I do not recommend
Holy
waiting that long.
moly!
I don't recommend waiting that long.
Sheeshki booshki. Why can't I have a baby? Just FYI. I
But
mean, I get that I'm over
Babysit my baby.
53
You can babysit my baby.
and I want to and I plan to. But seriously, why can't I mean, if you can get somebody pregnant,
you
why
could
can't you get somebody?
technically, right? Like,
Uh-huh.
but the
Way
happy
off topic.
parasite
I
inside the
love
older
yeah,
body is going to
yeah.
be very life threatening for you, right?
Oh, what?
Life
Listen.
Pregnancy is a life threatening condition for all of us,
Huh, how
and
about
I'll
that?
leave it at that. Okay.
Okay, fine. I
Um,
don't want to get pregnant, but I'm just saying.
yes. No.
Okay.
You
Actually,
could
I probably
technically. I could technically get you pregnant. Okay.
okay. My
Um.
husband might have something to say about that
Right.
party. He said, I think I'd like to get her pregnant, okay?
Yeah. Okay. But the what are we talking about?
We're talking about the weight loss medicines and how
Okay.
long you take them,
Right.
just till they
Okay.
get pregnant or what?
So so that they can use the medicines to get to the point where they can do anesthesia. As Kate said, 8 weeks, so 2 months you have to be off before the egg retrieval, and that's usually for anesthesia. because these medicines have such an impact on delayed gastric emptying. So, meaning the contents of your stomach sit in your stomach for so long that you're at risk for aspiration during anesthesia.
Like you're going to throw up because nothing's moving.
Correct. You're going to like throw
Okay.
up into your lungs. Can't do that during
No, I can't be
anesthesia.
doing that.
That's really bad. So for that reason, and because we don't know the effect on the eggs, hasn't been studied, these medicines are brand new, we want you to be off. Okay. So there's a 2-month washout, the 8-week washout prior to egg retrieval. Once we've retrieved the eggs and combined with sperm created the embryos can be frozen theoretically forever. So at that point, some of my patients may go back on the medicine to lose more weight. And the way I counsel them is I say, listen, typically in pregnancy, you're going to gain 20, 25, 30 pounds. That would be the average weight gain in a pregnancy. Now, we all know people who gain like 70 pounds. This happens.
Okay, it was only 50, but hey.
Okay. That can happen. And like Kate said, that ACOG is going to recommend, if your BMI isn't already in the obese range, that you basically stay stable. Nobody's going to ask you to lose weight, but we would ask you to sort of not gain any weight. And that's really difficult when you're pregnant. So what I tell patients is it would be a good goal to have to try to go down past your maybe goal where you are feeling really good, knowing that with pregnancy, you're going to come up to here. So go down even further to account for the weight gain you would expect to have in pregnancy. Because I counsel them as like a mom, it's really hard to lose weight postpartum. And don't count on yourself to be like a champion of weight loss with a newborn.
Yeah. So you would like them to get down to a point where at full pregnancy, at full term, you're not going to be over a BMI of 40 full term.
That would be ideal, but I don't, when I counsel patients, I empathize greatly with the struggle they've had their whole life, especially those PCOS patients, like we said at the beginning. Because I say, like, I'm sure you've had a million doctors say, just lose weight. And you're like, I've tried. I've done everything. Thanks so much for the advice. That was not helpful, right? So I empathize greatly with them about how hard this is. So I try to give them all the resources, which was something Connie and I had talked about when I first started at CCRM, because I saw a patient with a BMI of 48 and I came home and I couldn't sleep that night because I didn't know how to help her. That patient, though, after the counseling I did, one of my favorite stories, through diet and exercise and using my Fitness Pal, a free app on her phone, she lost the weight on her own, just diligently, 10 pounds a month for 4 months, and then came back to see me looking like $1 million, feeling like $1 million, ready to go. And I was just like, you are amazing.
I love
Continue
that.
to lose weight through the fertility journey. But yeah, so I try to give them all the resources. I tell them about the clinics that would see them at a higher BMI. I tell them what I can do for them. I tell them about weight loss surgery. I tell them about the medicines, and I ask them to go see folks like you to get further counseling, because I'm not a weight loss specialist. But I explain to them the dangers of getting pregnant at the higher BMI, because basically every risk that you can have in pregnancy is elevated with a higher BMI. So you are at greater risk of miscarriage, well, infertility to start, greater risk of miscarriage, greater risk of gestational diabetes, greater risk of hypertensive disorders of pregnancy, including preeclampsia, greater risk of blood clot, greater risk of labor dystocia, greater risk of...
What is that one? Labor who done what? Labor dystocia?
Labor dystocia, meaning you're more likely to end up with a C-section because your uterus can't do its normal contractions to push the baby out.
Okay.
Having a vaginal birth. So then you're more likely to have a C-section. Then you're more likely to get a wound infection. You're more likely to get readmitted to the hospital. And more likely to have congenital anomalies. Less likely for us to be able to find
congenital anomalies. Define congenital anomaly.
Sorry. Birth defect in the baby.
Okay. And the reason you're more likely to have that with a higher BMI is what?
Some of it's related to diabetes.
Okay. Oh,
Um, and then some of it is the limitations of technology to detect the birth defect and tell you it's going on so that you can make decisions.
okay. Oh, that's
So,
fascinating.
so it's like it's literally every risk of pregnancy is a little bit extra when the BMI is higher. So I do have the patients always talk to a maternal fetal medicine specialist, the high risk OB doctors, who also did OB/GYN fellowship like me, but went on the track where they wanted to take care of high risk pregnancies. Um, And to add on to what Kate said before, also post surgery, one of the special things we have to do is do their 1 hour fasting or their 1 hour glucose test is different because you can't drink that sugary drink because you would be very sick after bariatric surgery. So there's a different way
Oh,
we
wow.
check
How
it
do they do
based on
that?
last
Just
2
out of
weeks.
curiosity.
They have to do a smaller amount with the longer testing rather than chug this sugary drink and then check it 1 hour later.
Wow.
Yeah.
Yeah, so the oral glucose tolerance test, what is it, like 26, 28 weeks of pregnancy is a hyper concentrated sugar drink where it's like, what, 50 to 100 grams of sugar. It's like, I can't even
I think
remember
it's
what.
75 grams, but it tastes awful.
So in our patients, they would have dumping syndrome. It would not be a good idea.
Yeah.
So what we say to them is you still can monitor your sugar. We have them do a fasted like a blood glucose test, and they can do, it's a little bit more high maintenance, but they can do it like 3 to 4 times a day, like before fasting, morning, lunch, dinner. And then you do that for like 1 or 2 weeks to get some average sugar levels. So it is a little bit more drawn out, but it doesn't require the
Sugary,
slurry
awful.
of syrup that you
Yeah.
have to drink. Um, yeah. And, I'll comment on the approach to the treatment of issues with being overweight or having obesity and the class of obesity. So, overweight is over 25 BMI. If you start hitting certain thresholds of BMI, if your BMI is 27 and you've got comorbidities, certain medical conditions like we were mentioning, high blood pressure, et cetera, you qualify for some of the medications. So because obesity is a disease process, we approach it like we would any other disease process. Let's first start with medications. See if, now that we have more medications available to us, before we jump the guns with surgery, at least we do in our clinic, we offer both options for our patients. Once you start getting into the higher BMIs, you know, that's kind of when we start broaching into the conversation of surgery more so as a definitive weight loss and health improvement for these patients, that it's going to be longer term because obesity is a relapsing disease. And so it's a more of a permanent solution alongside our diet lifestyle, Connie. Um,
That's
Always an
required
asterisk.
regardless of the weight loss means.
So we these are the kinds of conversations we counsel with our patients. So it's also patient preference. It's also availability and access. It's also what they want. There are a lot of fears around surgery. So some of that is just understanding the truth behind the fear of surgery. Surgery is very safe, and patient preference, right? So a person who has a BMI over 40 is probably not going to have a lot of weight loss on medications. Like, depending where your weight starting point is, medications have limitations and won't drop you where you need to be versus having a surgery. But some patients, even if they have a higher BMI or starting weight, do not want to have surgery, and they've made up their mind. So we meet our patients where we are, and medications play a role in every stage of bariatric surgery. So we have patients who have been on all kinds of medications, injectables, coming up to surgery. We have them stop right before surgery. We let the metabolic effects of surgery take over at that point. And then usually at a later point down the road, if they hit weight stability and they've still maxed everything out that they've tried, it's not working, we pull meds back in again. And it's that adjunctive hormonal metabolic effect of being on these additional hormones, that amplify and kickstart their weight loss again. So it's an interest. I love hearing and learning from your specialty because, you're balancing the needs of your patient to have a baby, the timeline of that, the timeline of the whole ovulatory component to the cycle and all of that. It's very calculated. And weight loss improves fertility, bottom line, improves medical conditions. I think it does. We might have different conversations of what that weight loss treatment option is, depending on our starting point from a weight standpoint, because of the gravity of complications that could be added into the mix with the pregnancy. So there is that consultation, I'm sure, is very important to have with a patient. But the good news is there's lots of options, and there's a lot of options in the pipeline too that are coming,
Right.
which are looking promising. So,
One of the things that I think is really critical for anybody listening to this episode, especially if you're like, I want to have a baby and I got to lose this weight so that I can have the baby, is really listen to the part that both of these experts are talking about in terms of it's not just getting pregnant, it's the pregnancy, it's the health of the child, it's the health of the mother that can be at risk with this additional weight or the quick weight loss or getting pregnant too soon. Because I know from just working with bariatric surgery patients, it's like, blah, 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 blah. I just want to lose the weight. It's like all this, and if you want to have the baby, it's like, I don't care, I don't care, I don't care. I just want to get pregnant, right? But you need to understand that we want you to do that too. We want you to lose the weight. We want you to have the baby, but we want you to be safe and healthy, and we want the child to be safe and healthy too. So really, even though you're like, I've waited my whole life for this, and we will empathize with you and hold your hand and hug you and say one step at a time, because it's so critical. It's more than just about getting pregnant or more than just about losing the weight. So I kind of want to switch gear from the medical piece to the emotional piece. So Kate and I work with patients struggling with obesity all the time. So it's not a difficult thing for us to start talking about with them. Dr. Owen, from your perspective, say you have somebody coming in and they walk in the door and you see their size and you're like, oh shit, I got to have the weight conversation, right? How do you do that? Because that that's probably a factor. And I know there's probably things you got to do to definitively get to that point, but how do you address that topic? Because patients are so sensitive to, I don't want to hear I just need to lose weight.
Right. So what you just said just made me think, and I wanted to interject, like when a patient has a high BMI and they are in that mode where they're desperate to be pregnant, these are the hardest conversations for me to have. And like 70% of my job is psychological counseling at baseline, because infertility is so difficult and challenging emotionally. So when you add the piece where it's like, and I'm going to talk about this thing that is so hard for you on top of that, which is you're having trouble losing weight, and I'm going to create a barrier to your access to fertility by also, making it about this thing that you feel like you can't control, like just explosion, right? This is the worst. So I try to be so sensitive about it. And I always start my consults by saying, what brings you to come see me? And I let them tell me their story. And some patients will start off and they will offer it up. They will be like, and I have this medical problem. And they will say, boom, I have obesity. And some patients will not bring it up and completely ignore it. And I will go through my whole history taking process, and I'll have to find a way to kind of introduce the topic in a very, strategic but sensitive way. Like, I might ask them about their, I don't know. I feel like sometimes I'll just be looking at their intake form and it'll mention their height and weight, or maybe there'll be one comment where they'll say review of systems, and it'll say recent weight gain, or it'll say like maybe they have a thyroid problem, and I'll say like, has this affected your weight? Like I'll try to find a way to like incorporate it into whatever else we're talking about to show like these are all connected. This is not just like this other thing. But I always try to be really careful and not just straight up make it the first thing we talk about, because it isn't the most important thing necessarily that we're talking about. It's one of the many factors. And that's the thing with fertility is it's, I need an egg, a sperm, a hospitable uterus, open fallopian tubes, if we're going to do it in a semi-natural way. And then it's like, and I'm always on that thing, but then it's like, and then what other comorbid factors am I dealing with? Like he might also be obese, which can affect his fertility. You might have, thyroid, you might have diabetes, and is your A1C controlled? So there's always like all these things that I'm kind of like shuffling into order of priority. And then how do I tie it all together and try to get us to our goal, which is healthy live birth?
Oh,
So it
say those
depends.
last words again. Healthy what?
Live birth.
Healthy live birth. Absolutely the goal. So we are eating up this time, man. We could talk for days. I know we could. I just want to go to that male obesity and fertility thing for just a minute because it's so focused on the female because that's the carrier. How does obesity affect males' fertility?
A lot of it has to do with the fact that there's an enzyme in the adipose tissue, the fat tissue, called aromatase. And aromatase can take male hormone and convert it into estrogen. And so men who are obese will have high estrogen levels. And fun fact, you do require estrogen to make sperm. So you do need a little bit. But if you have too much, you get out of balance and their sperm parameters can suffer. Now, it's also important to know that if guys have a weight loss surgery and they have a huge dip in their weight very fast, that can actually be detrimental to their sperm. So they have to
In
be.
what way? Like count or
The semen analysis parameters can be affected. I don't know if it's necessarily one parameter specifically that is off, but we've just seen that, and I think it's nutritional. I think it has to do with nutrition, and it has. This is the way I describe it to patients, and I think this answers your question from before, where you said, "What is it about obesity that's causing infertility if you're outside of the PCOS realm?" And I think some of it's chronic inflammation from the fat tissue, and I think the way I explain this to patients is, listen, us as organisms, our body's first job is to keep us well. So whenever we've got something going on, diabetes, high insulin, a thyroid disorder, we've got cancer, like whatever the case may be, if our body's fighting on that front, reproduction will always be secondary function. Our body's, our body's job always second is going to be making good eggs and making good sperm. So if you thrust something into the forefront that is a major stressor for your body's going to focus on sending resources there first. So like with the weight loss surgery for the male, and the testicular factory is way more sensitive to this, because guys start making sperm at puberty and they will make sperm till they die. Al Pacino and Robert De Niro just reminded us of that. They can have
did
babies.
they not though? Holy moly.
So they will start making sperm.
They can have babies and they're older than I am.
Yes, that is the gift of being a male. But every heartbeat, a guy is making about 1,500 new sperm, constantly producing sperm.
Dear God.
So you can think of it.
Some
So you can think of it as a testicular factory, and if
it
anything
is a factory.
yes, if anything happens that creates a situation where the factory is not receiving resources, or if they get sick or something and the factory workers get put out, then you'll see a downturn in the semen analysis parameters.
The factory workers get put out.
That's right.
Okay, so I learned so much. So with the female of the species and the weight, and then we got too much of the traditionally male hormone going on, and vice versa with the men. Yeah. Well, for the love of Pete.
There's a balance. There's a balance that's
All
needed.
the balance, it is. And I think it's true. I mean, having obesity, and you have this hormonal imbalance across the board. You're right. We do. We see thyroid imbalances. We see hypothyroid. We see a lot of that regulate out as your body sheds weight and returns to normal BMI down to the 25s. It's really interesting to see that balance because your body starts to function more naturally,
So,
more at
Kate,
its
just out
time.
of curiosity, with the men that have weight loss surgery, which is a much smaller percentage of
Right.
our population, but do they talk about that in clinic?
No, they don't. I don't broach that. I used to work in urology. So I used to talk to men about their fertility all the time. It's mostly women now. They don't. I mean, they do when they get to a point, and it more so has to do psychologically from their social and self confidence and just dating more and putting themselves out there. Because what I find more is, the sheltering of their personalities, not dating because the weight is, the barrier to um, their sex life, their dating life for those that are single, even within their relationships. But um, in the literature, libido does increase. I think there is a correlate to that we see. And then also just their confidence and putting themselves out there more and having more of a drive, I think is,
Mm-hmm.
yeah, it's not the opening statement I bring up to my male patients, but I will say, tell me about your sex life. And it's just them and I'm like, should we have somebody here?
You know what, though? I think that would be a really, I don't know how to go about that, but I think men need to understand that because they may not understand that their fertility is being affected by their weight either. Anyway, another topic for
Well,
another
listen,
day.
I'm sure there are issues of impotence or struggles with erection because that is also hormonally driven as well, right? So, there is a sugar correlate to that, and insulin sensitivity plays a role in a lot of this because it's just blood flow. If you've got so much sugar flooded in your bloodstream constantly, it's like putting more cars on our highway system. It clogs everything up, and so even the delivery of the right hormones getting where they need to go and how things function is not going to be effective. Same thing when we see patients year out with plastic surgery. The reason we want tight sugar control is predominantly from a healing purpose as well. It's you need to have things in balance is basically where it comes down to hormones, sugar, everything. But so yes, it does impact men. Men tend to absolutely, I notice they drop weight faster than women. So unfair. It really is unfair. It's just the trend I see. And so they can kind of see faster weight loss, maybe faster effects than women. Especially because also our women are, some of them are older and they're perimenopausal and menopausal. So now we've got other hormonal issues that we're balancing as the natural phase, not of the fertile women phase, but the menopausal phase that contributes. So yeah, the male piece is interesting. Definitely a
Yeah.
part of the puzzle, especially from a fertility standpoint too.
Yeah.
So
It's I as I listen to Carter talk, I was torn between two highways in my professional career. One was going to be working in the field of infertility, and the other in the field of obesity. And it was so long ago that now you will find therapists, psychologists in medical practices. And I approached several OBGYNs in the Augusta area. Nobody was interested in it at the time.
Hmm.
But now it's a different story.
Oh my
And
God.
I
Yeah.
listen to you and I'm like, oh my gosh, I could totally combine my love of weight struggles. And all right, that's for a different day. But we are out of time. But I know listeners are going to have 1,000 questions. And so if you guys are game and we can figure out our schedules, because you guys are two of the busiest human beings I know, then maybe we can do a part two. But this is fascinating. But I want to give you both a chance to summarize if there are any additional points specifically that you'd like to make, so that the listeners hopefully have a better understanding physiologically about what's going on and why it's so important to wait to get pregnant as you're losing weight. Um, and a lot of the biological things. This has been fascinating. All right, we'll start with you, Dr. Owen.
Um, I think I'm just going to tell you all what I always tell my patients, which is there's always a way for me to help you have a baby. It's not if, it's how. So we just have to find the right path. And if weight has been a barrier for you accessing fertility care, you need a Connie, you need a Kate to help you figure out that piece of it. But don't neglect going to see the fertility doctor. You need all of us on your team to help you reach your goal. Age will remain your most important factor. So if you have eggs in you, all right, sperm source. um, but yes, age is really important, and the decisions we make and the treatments we use for weight loss may change depending on age because we have to balance, egg quality. But um, don't fret because there's always a way. We'll figure it out.
I love that message. That is so beautiful and so positive. And you, my friend, are totally in the right place.
Rock star.
Absolutely, for real.
Rock star.
Kate, how would you like to
I
summarize that?
would say, you know what, there's a lot, unfortunately, our society has put a lot of stigma around obesity and talking about weight, but it is an important conversation to address when you see specialists and infertility specialists. Talk about it, be open with your challenges, talk about potential treatment options, and work together with a timeline that works for you, knowing that we now are in an age and time where we have options that aren't as drastic as surgery, but surgery is still on the table, and it's really nothing to be afraid of. I know as women, especially when we are age focused and time focused, we want to jump the gun and we want to just have what we want to have. But at the end of the day, we want to have a healthy baby, like Dr. Owen said, and the healthiest baby comes from the healthiest mom. And what I love in this process is when I see these patients, surgery medications always come with a foundation of changes in diet and lifestyle. And what the beauty of that is, like, you not only are you being healthy for yourself and for your family, but you are now, through those changes in your behavior, you pass that on to the baby that you're building. So they are entering a healthier world, a healthier life, and that's a beautiful gift you could give to them. So I know it does take some time, but taking care of you first and foremost is the best gift you can give to your baby, that you're about to have and planning to have. So it's worth a little bit more of a wait, I would say, to do it right.
Absolutely. And that reminds me of something I wanted to get into, but we just had so much to talk about. And my parting message would be that it is about the long term. So please, if you are trying to have a baby and weight loss is part of that journey, don't just lose the weight to have the baby. Lose the weight to, yes, have a healthy pregnancy, have a healthy live birth, and also to exemplify a healthy lifestyle for that child. Don't just lose the weight to have the baby and then say I don't care about myself and gain the weight all back. Take care of yourself all the time. So, two of the women I admire and respect the most, thank you for both being on this episode. Hopefully we can reconvene and maybe maybe when the sun is shining, it's very late for all of us. But we got some busy young mamas there and a very busy grandmama here. So we had to, go into the late hours of the evening, but I appreciate you both so very much. And if you're listening to this, please share this episode with anybody you know who is struggling with any of these issues, male or female, and encourage them to see the fertility specialist, the medical specialist in weight loss, and of course the psychologist. I mean, don't leave me out here. I may be too old to have a baby, but I can work in tandem with these
Here,
friends.
Let's do shameless practice plugs. So I
Okay.
work at Beltline Health in Atlanta, Georgia. We offer medical and surgical weight loss options. So whatever you, or if you just want to learn, just come talk to one of us and we can just give
Right.
you what the options are. So you just have more information. And we obviously work intimately with Connie too. So you get two for the price of one with our practice. So that's where I work and that's where you can find me. But we have an amazing team of surgeons and advanced practice practitioners, dietitians, all of
Absolutely.
the support before and after surgery too, if you go the surgical route. That is lifelong, okay, not just at the time of
Right.
surgery. So, but even if you don't live in Atlanta, I really encourage you to reach out to a specialist of obesity medicine, whether they do the meds or not, or surgery. Just, know that there's a lot of safe treatment options out there, and you can find someone local to you where you live. Absolutely.
And absolutely. And I know Beltline has patients from all over the country who come in. And I know, Carter, you have patients from all over the country who come to see you too. So if you are willing, and of course, I will put Kate's information, and Kate's got a program called Banana Bariatrics. I will put that in the show notes. Carter, if you would like me to put your information in the show notes,
Yeah.
I know you are booked up for like 17 years.
But and also, well, CCRM also has a clinic in Atlanta.
Ah,
But I do telehealth. So if the patients wanted to see me specifically, they could come see me. We could do outside monitoring in Atlanta and they could still come up here. But
so if you have children that are like 4 or 5 or 6, I would make an appointment with Dr. Owen for like about 20 years from now. You can always cancel it. But that's
very
just my
funny.
suggestion. So all of this information will be in the show notes. And ladies, truly, I love you both. You're amazing.
Thank
And
you, Connie.
Thank
we
you,
had we
Connie.
also had fun.
This
Yes.
was
All
a
right.
lot of fun.
Good
Thank you
night.
so
Go tend to your children.
All right.
All right. Good night.
Bye.
much. Good night.